Namaste to everybody. Webinars also are becoming a disease now. And at the outset, I thank the AIUS and OSWB for having converged together for a common cause. And the topic is real life practice, not what is theory going on. As Mahipal had already hinted, we are living in a new normal, which needs a new calibration altogether. Tough times, believe me, as Madam also said, the President OSWB, Corona is likely to stay till vaccine or herd immunity comes. And Subhashish said we already started OPD, and Arup gave a very good account with a video. All precautions. We treat actually all patients as positive or carriers. That is the way to practice actually. Then only we'll take precautions if you are scared. We at Center for Sight have also started our operation theaters also. Initially, we started with emergencies and injections. Now, actually, we have opened for all surgeries. But patients, believe me, load is not as much as we are used to. Specialty surgeries are slightly more in number, but cataract refractive are also picking up, but not to the level of pre-COVID times. But believe me, all of us have to downgrade our expectations to around, as of now, around 40% or so. But time is a great healer, and I believe as the time goes by, things will improve. But believe me, as was told by Mahipal again, safety of staff and yourself is of paramount importance than just the numbers. So apart from livelihood, life also is very, very important. So everything you start slowly. First emergency cases, one-eyed patients, but observe what Arup also said, hand wash, sanitize, thermograph, social distance mask. Believe me, these are 5 things which are time tested. Rest all things come and go. But social distance, hand wash and sanitize, there's no replacement. As far as full PPP is concerned in the operation theatre for ophthalmologists is very, very cumbersome. All of us do take extra precautions in draping and double gloves, but full PPE, believe me, I never use. Because the whole game is that we have to reduce the risk to everybody. We staggered surgeries. We were used to, you see, calling so many patients, 40 cataracts, 4 VRs, 20 injections. No crowding in the operation theatre. And as Arup was relatives to wait outside in their cars preferably. And prefer all topical, local surgeries rather than GA. And PPE, as I said, only for aerosol generating procedures or for proven COVID. In any case, proven COVID it does not get operated in our hospital. As far as investigations, they have always been controversial pre-op investigations. But what we have been doing is hemogram, ECG, X-ray chest, or CT. In high-risk patients, we do get COVID screening. In a
I think we've lost the audio.
Yeah.
Board never rules out COVID definitively. For GA patients, yes, all patients COVID testing. For longer surgeries, yes. For comorbidity, yes, we do that. These are a couple of points which Dr. Namrata has put on the AIS website. These are all general guidelines. I'll not be speaking on specialty. I'll not speak on cataract or VR or other stuff, but I'll speak only on general guidelines. As far as recommissioning, we all take all these precautions. So I will not emphasize that air sampling before you start swabs. This has to be done. This is what we are not used to. The consent of staff we never used to take in pre-COVID era, and all the staff also has to have undergo scanning and history, as Arup said. This again we were all not used to. All the recovery room staff as well as pre-anesthesia, all these things have to be adhered to. Even people in CSSD area, they all have to have masks, 3-ply mask, cap, nitrile gloves, and face shields. Even OT staff and surgeon attire, you see, apart from all these things, protective goggles and face shield during surgery. This I found slightly cumbersome. I did try because Dr. Mahipal had insisted that around the microscope you should, but believe me, for a VR surgery, it was very, very cumbersome. So actually, I do not use this protective during the surgery on the microscope. Physical distancing, even in the operation theatre flow, you have to maintain this, and linen change has to be done as and when required and more frequent than we used to do in the pre-COVID era. Minimum possible staff within the operation theatre. In fact, we have not more than 30 to 40% staff we call, and segregate all the biomedical waste at source itself and ensure safe use of consumables. Safe cleaning of equipment has to be more often done than we used to do in the past. As far as air handling units and HVAC are concerned, we need to maintain temperature and humidity, and these are the 25 to 22 degrees centigrade and humidity around 50 to 70%. Try to try to have maximum air exchanges and fresh air intake. Usually it is around 15 20, but more than 30 is recommended. And for those who are having split ACs it can be used, it's okay. But recirculate air is single occupied in the OT complex. And again, temperature, humidity to be appropriately maintained and clean filter more often. And as far as GA patients are concerned, surgical team to enter after intubation and induction has been done. And after the surgery is over, surgical team waits outside the OT and degown only when the patient has been shifted. Biomedical waste disposal is important, should leave the hospital very fast within 24 to 48 hours. Instrument cleaning as usual, but autoclave with slightly more precautions appropriately. Patients attire, which we are not used to in the pre-COVID era, is all patients have to wear fresh, whether you have to give a patient brings fresh 3-ply mask after hand sanitization. And draping, you should do in such a way, take more precautions that during surgery there is no water or drained water is spilled, because this could be an issue. And aerosol generating procedures should be avoided as far as possible. Things like we always use valve cannula during surgery and try to avoid this spillage onto the floor. So these were a couple of points which I thought in the operation theatre as general guidelines we should follow so as to minimize the risk to the patient also and to the surgeon and staff also. Thank you very much for your kind attention.